Hey everybody, hi, how are you doing? Thanks for being here. So for those of y'all that don't know me, first of all, I say y'all and all y'all. Y'all is usually one person, all y'all is everybody. So just bear that in mind. So it's great to have y'all here. So I'm Kevin Crofton, I'm the chair of Creo Medical. And it's really great to have all of you here. I hope you learned something. I hope you walk out of here with a huge amount of energy and big smiles and thinking that the company is doing something that's, well, never been done before. And some of you have been on this journey with us for a while, and I think you'll appreciate with where the company is at the moment. At least I hope you do. On that subject, the company, the team has done an incredibly good job. We've hit our, well, every single quarter since I've been on board. Most of y'all know I started in July of last year, and for the last 15 months, I can confidently tell you we've done everything we said we're going to do each quarter, quarter over quarter over quarter, and we will repeat that again this quarter. And I can comfortably say that we are going to meet our objectives that we set when we went into this year. So hopefully y'all walk out of here understanding that that's actually real, not smoke and mirrors. Second of all, the team has done an incredibly good job launching products, not technology, products. And products has quite a meaning, but typically it's got to do something. It's got to be fit for purpose. It's got to deliver a gross margin. It's got to be reproducible. It's got to be deliverable, and it's got to be scalable. And I think that you'll see when you look at these products in the back, and when you hear what our august speakers have to say, hopefully you'll say, yeah, products, not technology. I hope you come away with that message as well. We have a number of folks that are here from the Creo team. Of course, we've got a lot of the engineering team here to give you an orientation on the products. At the breaks and at the end of the day, please, please, please pick their brain on these products. Touch them, feel them, move them. Not the guys and not the gals, but I mean the products themselves, okay? Take advantage of that as an opportunity. We also have some really interesting executives here as well from the management team. Over here on my right, we have Lewis, who is responsible for CMA, so Creo Medical Europe. If you want to know anything about that transaction, anything about how that's going, he's the man. Okay, make sure you talk to him. And then second, we have Natalie. Natalie's one of our VPs for sales, responsible for the majority of the North American area. So please pick her brain. She will tell you directly, I give you permission, directly on what's happening with the business, with your region. Enjoy that discussion, hopefully. And also, of course, we have David Wood here, David Woods, who you know, running worldwide sales for the company. And then, of course, most important for you and for us are these august speakers that we have in front of you. We have four of the leading key opinion leaders. By the way, one's still hiding over here, Carlos. We have some of the key opinion leaders in the industry here to talk to you about their experience on Creo's products and what they're able to do with Creo's products. And some of y'all that are investors, you might be frustrated, like, why does it take so long? It's because we're doing something new, novel, and different. It's missionary work. You got to have a strong stomach. You got to have intestinal fortitude to hang with it. Okay? So with that, I think those are my opening comments. I do want to say thank you to our speakers, Paula, Rosario, Carlos. Thank you ever so much. We haven't met, by the way, so Ben, nice to meet you. So please enjoy the day. Please feel some time to ask the docs here about their experience and what they're doing. Okay? Thank you, everybody. And I'll ask Craig to stand up and repair any damage I just did.
Thanks, Kevin. And again, just to echo what Kevin said, thanks everybody for taking the time to come in today. In particular, to thank the guys, Ben, Rosa, Carlos, and Palav for their input today. Really looking forward to exploring more of that for you guys. And this is really for you guys to understand, as Kevin says, really what the impact that we're having with our technology, with our products in the market, with your patients, and hear some of those stories bring it to life. We've got some exciting output from Palav's work, which we've been doing here in London on the pulmonary lung ablation side of things. And as Kevin says, we're really excited about where we are with the product range that we've been talking about developing and developing for the last few years since we essentially first went public. Some of those of you who have known for a long time will appreciate how long and hard a journey that has been, but we're now seeing the benefits of that in the market, and that's what's driving quarter-on-quarter results, which we're really proud of. Also at the back you'll see, and I hope you spend some time, and I'd love to talk to you about it afterwards, one of the visions that we've had, that I've had, is solving some of the challenges that we see in clinical practice, which in your day-to-day life, when you think about the products that you use outside of obviously medical devices, is an environment where products work together. They plug and they work together, systems integrate together and function. And one of the benefits of our technology, because it's integrated, it has to work together. Many companies have tried to do what we do and failed. But to do that on the scale with the range of devices we have, where you'll be able to plug and play, not just high-end, high-value, unique procedures that are changing things in the way that Palav is, but we'll also have commoditized devices that will mean that we have anything energy everywhere for endoscopy. So we'll be in a position in the next 18 months, 2 years, to have advanced energy everywhere endoscopists need to use energy. And that is on a plug-and-play simplistic basis, which you would expect in any of your technology. But it isn't something that's enjoyed in the clinic when physicians are using monopolar diathermy, which is, again, akin to where we came from. So the agenda for today is I'll speak a little bit about, just recapping on the vision and some of the enhancements. I've already covered some of that already, unfortunately. We then have a panel session with Dave and some presentations from our GI community. Ben from the US, Rosa, who's here in London and has been working on the product for a long time, and Carlos, who's pushing some of the boundaries of interventional endoscopy in South America, and one of the key opinion leaders from worldwide. We'll then post that, we'll have a session on bronchoscopic ablation with Professor Palav Shah from Royal Brompton, and then at that point we just start talking through with Charlie the adoption, the markets, what are we going after, and why these products fit in the markets that we're going after. So many of you will have seen this slide before. It's one that we reuse very often. My vision, our vision as a company, was we saw an opportunity to bring the sort of advanced energy that has been prolific in laparoscopic surgery as it has advanced over the years, from open surgery that moved to diathermy tools that used open surgery. This was laparoscopic open surgery, but really the thing that started to transform laparoscopic surgery and then later robotic surgery with the Da Vinci robots and those sort of things was the advent of what's called advanced energy, which is where the energy is controlled by smart technology. The products that are used don't put energy through the patient where they don't want it to be, and it avoids some of those remote site burns that happen with monopolar, very common. I talked to Carlos over dinner last night. He was doing a case with monopolar in the pancreas, and we ended up, when the patient ended up with a remote site burn in the lung, and the patient came back with a pretty critical complication. That cannot happen with advanced energy, and that's the progression of advanced energy. Our vision was always to bring advanced energy to flexible endoscopy. With this range of devices, we now have all of those devices at the back, all of which are generating revenue and all at various stages of their development as a product. We've evolved through that. We've had large speedboats, which people like the energy but found it difficult to use with some of the scopes in the market, and we now have the slim speedboat, and with the notch in it and some of the other features, which has really kind of been a bit of a game changer for us. The next slide. Oh, sorry, I'm the one in control. So a similar slide, really just looking at the evolution of endotherapy, and I think what we have at the back here is everything energy for endoscopy. That means we have to attack every case where an endoscopist needs to use energy. At the moment, most of it is monopolar because it's simple, easy, and cost-effective to make. The devices we have at the back are not simple to make, not simple to design, but we will be able to make them at a price point that is competitive with monopolar. That allows us to bring better, safer technology to the world of endoscopy. But if you look at the progression of endoscopy, endoscopy is progressing to become less of a diagnostic profession and much more of an interventional therapeutic profession. And so back in the 60s, the technology was the beginning of the endoscope, which is a looking glass into the colon and the esophagus or the stomach. the introduction of video imaging really started to develop the world of diagnostics and endoscopy. And then in the 90s, that's when high definition imaging, some of the more complex processing that goes behind endoscopy, and the development of basic resection techniques with monopolar really started to come into the field of endoscopy. And that's the beginning of therapeutic endoscopy really starting to take a hold. You look at 2015 to the present, you've got an adoption of some advanced energy. We are the only company, with the exception of possibly one with one particular balloon application, that is applying bipolar energy in the field of endoscopy. The integration of imaging, navigation, and advanced therapeutic techniques pioneered particularly in Japan, which is where the field has been developed using monopolar tools. And then the future we see is the ongoing expansion of endoscopy into third space or fourth space or interventional endoscopy as the profession becomes more therapeutic and less diagnostic. And included in that is the field of robotics as robotics comes into flexible endoscopy. 5 to 10 years from now, talking to Rosa earlier on about some of the pain she gets in her hand holding a manual scope, 10 years from now that's likely to go away with the advent of robotic endoscopes, and that's going to need precise advanced energy with control, and that's fundamentally our future, and these are the products that we believe are going to get us there. So very quickly, we've got two sides of the table over there. On one side, you've got the products that you'll see here, which you've seen and heard about a lot, those of you that we see on a regular basis. And the addressable market for the number of current procedures for that is measured in millions, if you look at the major markets that we're approaching things with. With the platform, it's unique in the fact that we plug and play with our devices. There's no intervention in terms of defining what settings the user has to use. It's designed for safety in a way that only we can do. On this side, we've got a wide range of additional bipolar devices which allow us to go after much more routine procedures with advanced bipolar technology. And the number of procedures in those applications is measured in the tens of millions over the course of the next few years, and it's growing at an appreciable rate. And what that gives us is a total addressable market for what we're looking at, which is measured in single-digit billions, but it's growing at a large rate. Charlie, when he speaks later on, will go into a lot more detail as to what drives those addressable markets, but what we're going after in terms of our drive to commercialization and profitability over the next 2 or 3 years is a very small fraction of that segment, but the combination of these two ranges of products is really key for us in terms of developing and expanding our footprint with the generator.
Thank you, Craig. So again, my name is David Woods, and it's a pleasure to be here. Thanks everybody for coming. We've got some esteemed speakers that are going to give their experience in terms of the technology and talk about the importance of what we're doing as a company. I just wanted to touch on a few slides from the business side, that at the end of the day, to be successful in our industry, you have to understand clinical benefits as well as economic benefits. So I'm going to touch a little bit on trends and things like that, and then I'm going to hand it over to the more important people giving their talks. So why is bipolar, RF, and microwave, why do we think it's going to redefine GI endoscopy? A couple of reasons. One, there's a rising GI disease burden and early cancer detection driving procedure growth. So procedure growth is growing everywhere. Hospitals and clinicians want safe, more predictable energy to take care of their patients. Many of them have value analysis committees, so they have to make sure that everything is safe and it's clinically beneficial and with economic benefits. Creo is the only platform unifying bipolar, RF, and microwave. So very different. There's nobody else out there that's doing that. And our advanced energy unlocks new endoscopic options that were previously out of reach. And Palav is going to give you a great example of that later on. So it's exciting. So what are the strategic market drivers? So there's a clinical need for more minimally invasive procedures. People want to do these procedures in a more effective way outside of the hospital environment, and it want to be easier on the patients. So that's a big push. Third space procedures are taking a lot of procedures out of surgery into the endoscopy suite. So it's more cost effective, it's easier for the patients. So these are big trends everywhere in the world. Growing patient awareness and preference for non-surgical procedures. So patients are getting smarter and smarter everywhere. They can go on the internet and they can figure out what's the best way to approach the disease that they have. So they demand this. There's demonstrated outcomes and evidence that it's in the best interest of the patient. I know the doctors are going to talk about this more than me, but there needs to be clinical evidence. Procedure volume, as I mentioned before, is moving to an outpatient environment, so it's easier for the patient. There's economic pressure everywhere. So as I mentioned before, there's value analysis committees. When they look at new technology, they want to know that it's going to save them money and be more efficient. Physician skill is expanding. These physicians are getting better and better, and in order to continue that, they need tools to help them do that. But we're seeing that everywhere. And technology innovation helps them do that. If you give them better technology, they'll take advantage of it, and they'll translate that to their patients. And we're seeing expanding indication, full thickness resection, obesity is big. So there's a lot happening there. So they have to have the tools to be able to deal with these broader indications. So what's the economic and workflow value of advanced energy? So when I'm talking to a hospital administrator, what am I saying in terms of economics? Why should they be doing this? So with our technology, there's reduced thermal injury, fewer adverse events, a lower total cost of care. And you can just see in these images comparing the Creo technology to legacy monopolar energy, it's much more precise, less damage on the tissue. There's more efficient dissection and coagulation, which means shorter procedure times. Everything's about efficiency. Everybody wants to do cases faster and safer. There's reduced need for additional tools. So with some of the tools that we're talking about, like the speedboat technology, it's multimodal. So it cuts, it coagulates. You only need one device versus 3 devices. So it's much better economics. Improved safety for advanced endoscopists. One of the things we're going to be talking about today is the continued growth of these procedures, and people learning these procedures have to learn safely. So it's really, really important. Consistent reproducible energy, deliver faster adoption and standardization, shorter length of stay. People want to get out of the hospital as fast as they can or not spend the night. And with these procedures, you can do that. And it supports expansion of endoscopy, advanced endoscopy lines, like I mentioned before, like bariatrics. So as I mentioned before, the doctors are going to be talking about their clinical experience and better clinical outcomes, but we also have to understand the economic outcomes and things like education, and we have to get validated publishing on both. So here's some examples. So Zach Ciamolis's study with 284 patients shows that they can do large polyps much, much faster than monopolar technology. So efficiency is really, really important. Dr. Jawade at Baylor basically showed he can do these procedures with 1 device, not 3 devices. So it's a lot more cost effective. And lastly, a multi-center study in Asia showed that young doctors could learn these procedures faster with this technology and safer with this technology versus monopolar technology. So from an economic perspective and a value analysis perspective, this is really, really important, and that's why I wanted to share that with everybody. But now I'm going to turn the mic over to our esteemed colleagues. First, we're going to have Dr. Rosa Vega, who is from UCLH. She's a very experienced interventional endoscopist. She's the deputy of the bowel cancer screening in Northern London. So now I'll turn it over to you, Rosa. Thank you.
Thank you, David, and good afternoon, everybody. I'm a consultant gastroenterologist, as David said, at University College Hospital just down the road. And I am the lead for all the interventional endoscopic procedures that happen in the large bowel in the hospital. And hopefully, within the next 10 minutes, I'm going to give you a bit of a reality of what we face as doctors. And with the slides that I have prepared, you will see my journey in order to help the patients without causing harm. That is always something that we want to do. Now, let me see if I can work this. The next slide will be that. So, as I said, I deal mainly with either precancerous or cancerous lesions in the colon. And bowel cancer is a very common type of cancer. We would say it's the 4th most common cancer in the UK. and the second most common cancer that causes death. And in the UK, we have 69.23 million population as last month. How does the cancers appear? When I say bowel cancer, for those of you that maybe have forgotten a little bit about biology, the bowel cancer usually originates in the large bowel and starts with a benign polyp that when you have your diagnostic colonoscopy, sometimes you have removed. And if these polyps are not found or removed, it takes about 10 to 15 years of multiple changes in the cells and the genes and nuclei of the polyp to develop into an invasive cancer that unfortunately the only cure is to remove the bowel surgically to get rid of the disease. Now, when you have surgery, it obviously cures you of the condition. However, surgery can be quite mutilating and sometimes leave patients with long life-lasting consequences that affect their quality of life. For instance, if your bowel gets formed in the left side of your bowel, and this is the area that needs to be removed, most likely, if the cancer is very close to your back passage, you will need to have a stomach bag in your belly in order to produce your feces on a daily basis. And obviously your cancer is cured, but quality of life is affected. Also, having bowel surgery comes with complications, and sometimes things can go wrong. And our surgical colleagues do a great job, but they are major surgeries. And this is the data published, that is in the public domain in 2020, of the outcomes that happen at University College Hospital, where my colleagues are highly experienced and do a fantastic job. But as you can see, they do nearly 400 operations of bowel cancer a year, of invasive cancer. The mortality rate is about 1.7%. Usually patients stay more than 5 days in the hospital, and patients may need to come back within a month in about less than 10%, but still it creates a lot of pressure in a very busy NHS setting. And obviously they are already doing 400 operations a year of these invasive cancers. So if there is something I can do to take some of these cases away in early cancers that I can remove endoscopically, that's going to reduce pressure. Now, when we diagnose bowel cancer in the UK, most of the diagnoses happen when patients have developed symptoms. However, there is a 10% and is on the increase because of all the public health promotion or so forth, that cancers are diagnosed through the bowel cancer screening program. For those of you in the UK, you may know that the bowel cancer screening program here invites individuals to participate on the screening between the age of 50 and the age of 75 by doing a stool test, and if the stool test demonstrates presence of blood, then you have a colonoscopy. Most of the patients have not developed any symptoms at all. It's just through the analysis of this test that the colonoscopy is done. And when we diagnose these cancers on patients participating on the screening, what is very interesting is that most of these cancers are on a stage 1. What it means, it's an early stage, and there are things that can be done endoscopically to cure these cancers without the need of performing surgery and leaving the patients with long-lasting quality of life problems afterwards. So, because of that, the European Society of Gastrointestinal Endoscopy has recognized that endoscopic treatment of large, complex precancerous polyps or cancers need to be treated slightly different if they are on a very early stage. And for the very first time a couple of years ago, recognized in their guidelines that an endoscopic submucosal dissection would be the mode of removing these early cancers in patients that fulfill the criteria. And now I'm going to explain to you what is exactly an endoscopic submucosal dissection. Here you have a diagram of what the bowel looks like, right? Our feces travel through here. That's the inner layer of the bowel, and then we have several layers until we reach the muscle. So early cancers or complex polyps, they develop in the inner layer of the bowel and progress through the stages until they invade the muscle and go beyond the bowel wall. I think it's clear, right? So when we are performing an endoscopic submucosal dissection through a colonoscope, so these flexible scopes that we can introduce inside patients' bodies in a colonoscopy through the back passage, we are feeding instruments to allow us to peel whatever is happening. That would be the inner layer of the bowel, that would be the muscle. So with our devices, we can peel between the muscle and the inner layer of the bowel. So if there is a complex polyp or a cancer that I have represented here with a star, it can come out all in one piece, but still preserving the bowel wall. Therefore, the patients can recover much faster, don't have any they don't have a major surgery, and they can do better and regain their functional bowel as they would. But what are the sort of challenges of doing this procedure? I have explained it to you in 5 minutes, but it's an extremely slow technique to learn. First of all, because we are working in a very complex, difficult organ that is a bit bendy. Secondly, because we cannot peel it with our hands. We need to use instrumentation that is about 1.5 meters away from our hands. And we are peeling areas that are only between 2 and 4 millimeters of thickness. And if we go a bit deeper, what happens is that we cause a perforation, and then the patients need to have emergency surgery. So we have to be extremely slow, and the learning progression, unfortunately, is not very quick. As David and I think Craig mentioned, these techniques were first described with success in Japan. In Japan, the prevalence of cancer in the stomach and the gullet is quite high. So the doctors in there were able to learn to do these techniques in 2 organs that they are a bit thick and they are straight. Therefore, you can practice in an organ that is easy to do. Unfortunately, or fortunately, depends on how you see it, in the Western countries, the cancers in the stomach and the esophagus, the gullet, are not so prevalent, but we have a lot of complex polyps and cancers in the bowel that we need to deal with. And if we have to wait to learn practicing our skills in the stomach, probably we won't ever learn to the level of sufficiency, so we have to learn in the most difficult and complex organ that we have available. So, how did I come with all this venture? Obviously, I was seeing more and more patients that cancers were diagnosed in early stages, that doing a surgical procedure was probably a bit too much for them with the complications and mortality rates, and removing these polyps not in the right way to peel the polyp completely or the early cancer didn't sound right either. So, there were lots of monopolar devices, as they have mentioned before, that they do the job in skillful people that had been done that for 20 years in Japan. But these monopolar devices, the type they deliver the energy, can cause harm if you touch the muscle, and you can potentially perforate. So I didn't feel extremely confident to learn, and I didn't have, in my specific individual case, the opportunity to drop everything at UCH and say to all the patients, wait, I'm going to disappear for a year because I need to go to Japan to learn, and then I'll come back. And then Creo, and it's a reality. There are quite a lot of my colleagues that were able to do that, but in my case, I couldn't. I had a lot of patients and things to deal as other venues I do at UCH. So Creo Medical approached me just to say, we have this new device that delivers different type of energy. We combine bipolar radio frequency with microwave. We think it can be safe to patients for the way we deliver energy. Learn with it. And I thought, why not? So the difference in between the two types of energy, just for you to be quite clear, is that when you use a monopolar device, it means you have a little positive cath that delivers electricity. You have to have a receptor at the end of it. There is quite a long journey, and in between you need to cut some tissue. So the amount of energy that you deliver is not very controlled because you need quite a lot of it. Whereas when you have a bipolar device, means that in the device itself is the only journey the energy travels. So it can be much more controlled, and you can decrease the energy by 1/10. And when you are using microwave for coagulation rather than radio frequency, is exactly the same. Microwave, everybody has got a microwave at home. You may overcook a bit tissue, but it never becomes carbonized, right? So it's the same in here. You can create a coagulation just by increasing 90 degrees of Celsius of temperature, but you don't burn. And that's why it makes it also safe. So in 2019, I had my first training course with Creo Medical, that they had a very structured training course with very good syllabus, and then mentoring afterwards. I was able to put a business case together in the hospital to say that makes sense from the cost-effective point of view and also from patient safety point of view. And I did my first case in September 2019. And I was lucky enough that the whole endoscopy department didn't close, so I could continue doing some cases despite the pandemic years. So I just going to show you a quick clip of 2 minutes of what exactly an ESD is about, so you can sort of get it. So here you can see that's normal bowel, and in here you have a very complex, very flat polyp across the bowel. And what I'm doing with the speed the boat device that you can see here at the end of the scope is just demarcating the area where I need to cut. What I have created here is a blister of fluid with a bit of blue dye to help me to highlight what is polyp and what is normal bowel. And very slowly I am disconnecting the inner layer of the bowel from the deeper layers and the muscle. So very slowly opening here a window and just peeling nicely and controlling, and if there is a bleed, I can do. So I have already created a tunnel. This white bit is the muscle. I have the polyp here on top of me, and I am continuing to dig deeper in between the muscle layer and the inner layer of the bowel in order to keep peeling the polyp away from the muscle layer. And you can see it cuts very nicely. There is no carbonization because of the way the energy is controlled, and that also increases very nicely the visualization because you can see at any point what you need to cut. Now I just need to connect the sort of two lateral sides that are still attached in here, very slowly and very precisely. It's all very neat. There is only this segment here that needs to be dissected. And very soon you will see that's the last strength that I need to dissect. This would be what the bowel continues. And now I'm cutting through the other side, and you can see blood vessels in here. I'm using the microwave just to coagulate them. There is no carbonization. They just get blanched very neatly with no bleeding whatsoever. And this is the polyp that I just peeled, that we analyzed, and is a very early cancer, and the patient was able to have a curative treatment without the need of surgery. I've done a total of 275 cases since 2019 with lots of very good outcomes. You can see polyp diagnosed, polyp resected, in the piece of cord to be analyzed, and how it looked 6 months later. And lots of, I just put here a small example of a patient testimony, many of patients being very, very grateful, especially for those patients that we save a mutilation surgery going forward. Since I have a passion for training and mentoring and trying to spread this technique skills to the rest of people in the UK and further afield in Europe, because I think from the patient outcome, safety and satisfaction point of view is great. And I have participated in many life endoscopy courses, and I continue mentoring young colleagues to adopt this type of surgery in order to be more of us that can do this type of procedures. We have also produced, Creo Medical is helping with some funding at University College Hospital in order to have research fellows that can help putting data together. Because when we are NHS physicians, we are incredibly busy with everything going on. So having people managing data also helps quite a lot. And that's been very important in order to produce data there. We have presented several already research projects in our international prestigious meetings, where we have demonstrated that we have incremented the number of cases that we do every year, because obviously there is an increased flux of referrals, and we become competent, and I can train other colleagues that can take cases on board, so we can do more and more cases with very good outcomes, with very low profile of complications. We are below the sort of international average with a 2% perforation rate, which is really, really good, because 275 cases may sound a lot, but they are not so much. So it's not so many cases that are done so far. There are people out there in the world that have done more, and my quality performance indicators using this device really are translating to be a very safe energy to use in my hands. We have also produced data in terms of our cancers and the cancers that we have been able to cure just with an endoscopic procedure and avoiding patients having surgery. Obviously, we have been able to resect 25 of them. And then once we resect the cancer, is down to the analysis of the type of cancer to see if any further surgery is needed, if there is some suspicion of possible metastasis. But at least we can produce a very good quality histology that can give the chance to patients not to have surgery. We have published also case reports. That's a very interesting patient. It was, even if it's not very well described, an emergency endoscopic submucosal dissection. A patient in her mid-60s that had a very large polyp in the lower end of the bowel that keeps secreting a lot of mucus. Therefore, she was developing renal failure because of the amount of fluid that the polyp was secreting, requiring being in ITU several times despite replenishing the fluids. And we squeezed her in between, because obviously she was in and out of ITU because of renal failure, the kidneys failing. And we managed to remove this 14 centimeters lesion from the lower end of the bowel safely in 6 hours, which is not a very long time for such a big polyp. And actually, the patient recovered very well and never had any problems with her kidneys anymore. So lots of successful stories. So my collaboration with Creo Medical nowadays, obviously, I am a member of the Innovation Council that I run, that Charlie chairs, and and I provide my clinical input in order to develop new devices that can adopt this type of technology to make endoscopy therapy safer. I also a trainee on the Pioneer program where we train other doctors and mentor other doctors in order to adopt this technology, and obviously wishing that this technology is helping more and more interventional endoscopists to be able to train in this type of procedures. And my final thoughts before I stop is that I think with the current climate that we need to do interventions that they are cost effective, that we can shorten, especially here in the UK, NHS setting, the length of stay, and that we can keep good performance indicators and patient satisfaction. I think the devices from Creo Medical align with this type of thought, and basically happy to continue collaborating with them because it has provided very safety platform for me to keep treating my patients.
Now I'd like to introduce Carlos Robles. He's the head of endoscopy at the Ecuadorian Institute of Digestive Disease. He is an interventional endoscopist that does a myriad of procedures, significantly published many articles, and very innovative. Carlos?
So, good afternoon. Thank you so much for this kind invitation. For me, it's a really pleasure to be here. I want to ask first, Dano, how many of you are physicians here in the room? One? Okay, so it's good. Fantastic. So the second question is, anybody have fear about bleeding or blood or something like that? Well, it's okay. So it's fantastic. So I would try to talk a little bit about not just my experience. I believe the talk of Dr. Vega and the other colleagues will be amazing because I believe they will show it what I already have as an experience, as Dr. Vega said. But I want to make a presentation in another perspective, in the perspective from the physician and from investors and in the size of the company, right? So I will talk about the bipolar and microwave technology that is Creo Medical Chroma technology that you have, the present and the future, right? Because as investor, yes, you want to put money there in the company and say, yes, I want to invest because the revenues are good, but how big could be these revenues in the future? And that is important also to understand a little bit. So next slide, please. I have this. So a little bit talking not too much about the background, but we need to understand why bipolar energy, and I believe already many of the persons that make the presentation showing a little bit why bipolar is important. It's important because we can avoid a lot of complication during minimal invasive endosurgery, you can say, or endoscopy procedures. And this is very important, you know, because you have better precision, less collateral tissue damage, and improved safety compared to monopolar energy, right? So as was mentioned also, the bipolar electrosurgery use two electrodes. You always will need two electrodes located in the same instrument. It means the energy is in the tip of the device and not other way. So that's make it safer. And this provide high localized heating, reduced thermal spread, less risk of stray energy injuries, better control in confined space like GI tract, ENT, laparoscopic surgery, and also robotics. I will explain a little bit what is microwave. It's the same that you have in the cell phones. How many cell phones are here? I have cell phones. You have well, the same microwave, right? Is using to make coagulation, but also to destroy tumors, which is amazing, right? But I am really grateful for this invitation because I learned a lot. I had to read a lot of the engineering part because I want to understand what I am saying when I came to here to give you a lecture. So the application in medicine are a new field of growing interest with a significant trend in healthcare research and development. The first application of microwave was in 1980s, was for tumor ablation, and we continue in this, platform for the treatment of cancer, and their application have been expanded. And as a microwave energy is a form of non-ionizing radiation. This is very important. This is something that we probably don't understand too much, but everybody knows X-ray, right? X-ray, CT scan, right? Radiation. Radiation is not good. It's good, has been the technology that we needed to use it during the last 100 years, but it doesn't mean that it's perfect. So we need to move to new technologies like this one. So it doesn't make any alteration of the molecular structure of biological tissue and has a significant biomedical application. So this is something that you already saw it, right? You have an advanced energy platform, you have an advanced energy instruments, and we need more of these. And we have endoscopic instruments with Creo Medical right now. So I will show a little bit the evolution of this speedboat that you investors investing on this. But this is how when Dave visited me, and I think 5 years ago, 6 years ago, something like that, I saw 15 engineers, amazing engineers, in my unit, and we were working and we were talking about all this technology. And this helped us to start to come from the speedboat 3.2 millimeters to the ultra slim, and you can see how the energies distribution is much better. And the evolution now, I really like this notch speedboat, and the design, just this change, a small change in the design, could be like easier, but no, we need to think a little bit more on this, because the energy concentrates more here, and this special area, that is the notch area, increase the microwave coagulation, so it makes it easier for me. So right now I'm very happy, to be honest, with this. I will show you what we are doing right now with the technology. This is Dr. Daniela Tabachela. She's in Romania right now. She was my fellow 2 years ago. And Creo bring to me these scissors, and I start to use it. I really like it, the concept, and we start to see some new applications. As Dr. Vega showed you, this is a polyp in the duodenal part. So monopolar sometimes is very risky in this area. So Daniela was the first time using this, to be honest. She never used it before, and she did it right away without any training, and it was during a live course with 7,500 physicians looking in 87 countries. So it was good, because they sometimes have fear about myself, because he bring me something and I say, look, I want to go live, and he say, no, it's not good, because I say, look, I believe it's good and we will do okay. So this was one of the crazy things that probably I made it, but I am showing you the way that Dr. Vega was showing her resections. You see no bleedings. Very nice case. No perforation, no risk of perforation after that. And you can see how it cuts very well. And no risk of, later perforation because of monopolar. And this was made in 12 minutes. You see? So it's just that. Okay, I will continue. So we need to understand a little bit also about microwave technologies in medicine. As I mentioned, it's a non-ionizing spectrum that goes from 300 megahertz to 300 gigahertz. So this could be applied as a thermal and non-thermal biological interaction. I would like to talk a little bit about the thermal biological interaction with the microwave technology. This was the first case that we made in a patient with a renal failure with this pancreatic tumor, neuroendocrine pancreatic tumor, unresectable because of her renal failure and all her conditions, but also because of the size of the lesion. And we applied this technology to burn, to destroy the lesion. This is the result. So you can see how it's black is because of the tissue of the cancer, right? And then once it becomes white, for me, it's okay. It means I destroy everything. And I confirm 2 months after, the patient is still alive. She will die for sure one day, as everybody, right? But I believe not for the cancer right now, okay? So, which is very good. I would like to talk a little bit about the future. It means what we'll have as a new advanced energy endoscopy instrument, what we need, and what we can create in terms of microwave technology in medicine, non-thermal biological interaction, and AI, and also bipolar technology and AI, because I believe it's part of the future, and these have a big potential because, as you already mentioned, you are unique, to be honest. You are, because you are investors also of this. So in terms of immediately, for me it was a surprise to arrive here and to see exactly what I needed, with the exception of this. But all these new ideas or things that we need in our job is necessary, but now is possible because you already do it, which is fantastic. But we were discussing a little bit about new things that we need, and I believe it's easier to do it in the next months or next year, probably. But the thing of AI enhanced bipolar energy is very important because and it's very interesting because of the clinical advantage. You have more precise optimal energy doses, safer, lower risk of injuries, and more reproducible standardized procedures, right? So one of the big advantage how AI will enhance bipolar energy is that we will have a real-time tissue characterization. It means AI will classify tissue type by analyzing sensor data on your device that you have. It could apply intelligent energy modulation. It means the tissues are not the same from a small kid, my age, and older age, or it depends on fibrotic or other kind of situation that you had in your life. But AI will adjust this energy to have more specific tissue subtype and avoid. If we have almost zero complication that Dr. Vega showed, I believe we will arrive to zero, and that is amazing. So we can have a predictive safety monitoring. AI detects early signs of excessive heat, for example, and make an auto-regulation as your cell phone. When the cell phone starts to hit, it's quickly, stop everything, and then we'll be fine. And this integration with imaging and robotics will be fantastic for the future, and I believe it's not so far of that. So the other thing that I believe is very interesting in terms of microwave is about the principle of dielectric properties, contrast, sensing using microwave. What it means is it's too much, right? I didn't understood until I read it before to coming here. So the thing is, the microwave, we have microwave right now working here because we have all the cell phones on. So these sensors, yes, pass through the tissues, and we can predict just by analytics. It means AI. So if this tissue is normal or is abnormal, it means there is something happening there, like inflammation or infection, and even tumor. So that will be a game changer in terms of the future for this. It means we can, with these dielectric properties, contrast as a biomarker, and will help us a lot in diagnosis. Dr. Vega was saying about diagnosis is a little bit tricky in terms of growing up, cancer at early stage, and microwave can help us with that, with this. So we have several technologies now that are under investigation, but the future is very interesting of using microwave accelerated metal enhanced fluorescence. It means with nanoparticles, nanotechnology, we put some metals and we can increase the fluorescence of the cells that we have, and we can increase diagnosis of this, not just for immediately diagnosis, but we can have ultra-fast detection in second, very low detection limits, and ideal for point care of diagnostic virus, bacteria, microRNAs, proteins, oncologic biomarkers, and intraoperative detection. It means if a surgeon goes inside, imagine to have this technology with microwave to see much better, not just with the eyes, looking at the cellular level. So it will be very interesting. And this is all the possible application of this technology in the diagnostic area. It means blood pressure stimulation, the electric characterization that I already talked in, the liquid detective characterization, because a tumor, our bodies is composed of water, but a tumor doesn't have the same quality and quantity of water. So this will help us just to predict where is the lesion, because sometimes the small bowel on the body, move. So we can measure the blood levels of glucose, for example, for monitoring this by wireless, not to pick, the diabetics have to pick and then to put the blood there, and it's a lot. One needle for me is the nightmare, right? So and we can see other things and also destroy tumors and continue to improve this. So the applications in modern medicine, I believe, will be non-ionizing technology, enabling to safer diagnostic and therapy, with AI enhanced clinical decision-making and reconstruction speed and workflow efficiency, and application span imaging, molecular diagnostic, ablation, pathology, telemetry, and waste sterilization, that I believe is something that is very interesting for the future. So AI enhanced imaging diagnostic, we will have leveraged the electric contrast for non-invasive radiation-free diagnostics. That I believe will be part of the future, and also the revenues of the company. Deep learning accelerates reconstruction and increased diagnostic precision, molecular diagnostic, and the electric spectroscopy for high accuracy levels. In terms of therapeutic application and emerging technologies, we already have that, and we talk about these ablations tumors. We have a lot of data worldwide right now. But I believe this is very interesting in terms of drug delivery accelerating using microwave, activate nanoparticles. It means we can treat with pills, with drugs. We'll say an antibiotic, and we can amplify this antibiotic to treat. So we can diminish the doses. Even we can treat the infections just by microwave, which I believe will change. This is a game changer for the future. And also sensors and telemetry enabling continuous remote monitoring will be easier. Imagine that you go home, and I don't know, daddy or mommy or some family person at home, moreover in older population like Europe, for example, there is increasing and increasing. So these people doesn't have this kind of change. But if you have remote telemetry, sending information to the physicians, so you can even prevent a stroke or treat the patients quickly and in an easier way. So you are here. This is where you are. So microwave ablation in treatment in endoscopy is fantastic, and for robotic and for surgery and for pulmonology and all of these areas. But you have just one part of 10 possible development. It means more revenues, more other areas that will be very interesting for the future. And this is my last slide. What should we understand from this? So for me, microwave technology are shifting from niche tools, like you have right now, to mainstream medical platforms. This need to see as a platform, not just as a therapy, right? That could increase healthcare technology to treat patients and diseases, but also increase sales and revenues for you. Second, AI integration transform data-rich microwave and bipolar system into precision diagnostic and therapeutic device. This is the mediate feature. clinical impact, faster diagnosis, minimal invasive treatment, and improved patient outcomes. From the investor perspective, I believe a scalable hardware, AI software stack, multi-market expansion, especially in oncology, pathology, imaging, telehealth, sterilization, including surgical, robots, and devices, and high growth potential driven by unmet needs in non-invasive diagnostic and target therapy. So thank you so much for your attention, and sorry for the video, it doesn't work, but it was amazing. Thank you so much.
Thank you, Carlos. I appreciate it. And next, I'd like to introduce Dr. Ben Tharian. He's at Digestive Health Institute in St. Petersburg. He's an interventional endoscopist that does many different types of procedures. He has had training here in the UK. He spent some time in Australia, and now he's in the US, so he understands healthcare dynamics around the world. Ben.
Thank you. Thanks so much. Thanks everyone for coming to this meeting, and thanks for this invitation. Right, so how I am different from these guys are all researchers and clinicians. I'm a pure clinician. So I do a lot of clinical work, and as I was mentioned, I am licensed here. I do have my British license still, and I'm licensed to practice in Australia and in the US. I'm an interventional endoscopist. I do a lot of stuff. But my focus today at this meeting would be to talk about what POEM is. It stands for per oral endoscopic myotomy. It's a minimally invasive technique that is essentially used to cut the muscle. All this time we were thinking about how we should avoid cutting muscle. So this is a technique that is used, where I use the device to actually cut the muscle. The principle is different and the indication is totally different. So per oral endoscopic myotomy, we create a tunnel. Just like what they do, we create a tunnel by raising a bleb, go in the submucosal plane, that means underneath the lining, and over the tunnel, over the muscle layer, I go deeper down and cut the muscle as much as I want. And then I pull out the scope, and I have endoscopic suturing devices with which I close the hole that I made. So you must be wondering why am I cutting the muscle and coming out? So there are different techniques, different indications for the POEM or the per oral endoscopic myotomy. One is the E-POEM. E means esophageal poem, or they might call it O-POEM here in the UK. So E-POEM is done for treatment of achalasia, diffuse esophageal spasm, hypertensive lower esophageal sphincter, and spastic disorders. So achalasia is a condition. Achalasia is a condition where you have difficulty swallowing. It could be seen in young kids, or it could be seen in people who as old as 80 or 90 years old. The problem is the muscles go into spasm, and the esophageal muscle does not contract. So they present with difficulty swallowing, and all the food that they swallow gets stuck in their esophagus, and you aspirate it. Everything just spills over into the lungs, and patients might present with pneumonia. Very bad disease. I've got a young 20-year-old kid who had done a POEM on, who's back to almost normal now. So you diagnose achalasia and these esophageal dysmotility conditions by doing high-resolution manometry, by which you classify using the Chicago classification into multiple groups. These are the areas that we can treat using the POEM technology. Achalasia, 3 types of achalasia, and EGJ, that is esophago-gastrojunction outflow obstruction. So these are all disorders of the outflow tract, that means from the esophagus to the stomach. The outflow tract is obstructed, so food is not going down. And the other system is where patients have disorders of peristalsis. That peristalsis is the normal wave-like movement by which food is pushed down. So disorders of peristalsis where patients have esophageal spasm, or hypercontractile esophagus, where the esophagus goes into spasm and you have severe chest pain and patients present to the emergency department thinking that they're having a heart attack and they're not able to swallow anything. The moment they eat something, the esophagus goes into spasm. So very uncomfortable disease that doesn't have many other treatments, options. So this is just, I don't have many slides, I'll make it very quick. So here we are actually cutting the muscle, as you can see. You're using the speedboat device to cut the muscle, and that's the inner circular layer of the esophageal muscle that you're seeing. So I'm in the tunnel. I go underneath the lining, and I'm cutting the esophageal muscle deeper, and you go deeper, then you go into professor's territory, into the lungs. We don't want to go there. So we stop short of the muscle. So as soon as the muscle is cut, we stop. We can easily see that we have reached the mediastinum. So the clinical evidence, the evidence of the efficacy, there are several publications from Kashab in Johns Hopkins and others here, which have shown that the efficacy of POEM for achalasia is the order of 97 to 98%, compared to the previous traditional treatment, which is called Heller's cardiomyotomy, which is a surgical procedure, an open surgical procedure or laparoscopic procedure. The other condition which I mentioned, where patients have severe chest pain, jackhammer esophagus, the success rate is about 75%. So I've done several of them. Patients actually have significant improvement with that, and they're able to go home within 24 to 48 hours. So how does this compare the POEM versus the surgical approach, the Heller's cardiomyotomy? You can see that the success rate, the clinical success is comparable between the POEM and Heller's, slightly more success with the POEM procedures. Hospitalization, although it is shown in this study that average hospitalization is 1 to 2 days versus 3 to 4 days for Heller's cardiomyotomy. We have been sending patients home the same day. About almost my last 30 or 40 patients who have undergone POEM procedures, we send them home the same day, because we are able to suture the mucosal defect that we make, and we are able to say that there is no leak, and the patients are able to go home with no medication, just some antibiotics. Post-operative pain with this POEM technology is minimal, because there is no external incision. As they said, this is all internal, all mucosal incision, and with this technology there is no heat dispersion, so the complications are very minimal. So patients are able to go home on Tylenol or paracetamol. So very minimal pain medicines and antibiotics. The recovery is pretty good. Patients go back to work within a week and almost back to normal. There is a slightly higher risk of reflux compared to surgery, but the vast majority of this, less than 10% of this, will need some medications. And even a smaller percentage of them might need some surgical treatment to fix the reflux. And we can do it endoscopically. I do endoscopic fundoplication, by which we can actually fix the reflux as well if we do need it. And it's been shown that for type 3 achalasia, which is one of the classifications I showed you, the POEM technology is much superior compared to the surgical option. And this is the recommendation, the latest recommendation from the ASGE and the AGA, which have shown that for type 3 achalasia, POEM is preferred compared to the surgery, whereas for type 1 and type 2 achalasia, either of those treatment options could be used as first line. Now, I just mentioned to you about the esophageal POEM or the EPOEM. There are other POEM technologies as well. POEM can be done in the zengas, in the neck. So patients might complain of difficulty swallowing with aspiration pneumonias, because they have a small pocket behind the esophagus where when they swallow, the food goes into the pocket rather than going into the stomach. So you can do endoscopic zengas diverticulotomy using the same device with a speedboat, and patients are able to go home the same day and are able to swallow food the same day. The other technology, other situation where you can use the POEM technology is in the stomach. Patients with a bad disease called gastroparesis, where the stomach is not emptying, the stomach muscles are sort of paralyzed. You're able to cut the stomach muscle at the pylorus, which is the gate or the sphincter at the opening of the stomach into the small bowel. You're able to cut that muscle open to release the sphincter so that patients are able to swallow food and are able to digest it, rather than the food just staying in the stomach. So there are different indications for the POEM technology. Now, the reimbursement. I work in the US, so reimbursement is extremely important. So no hospital is going to support you if procedures are not paid for. So until 2022, we did not have a CPT code. CPT code is the reimbursement code that is needed to get insurance to pay for it. So since 2022, we had a CPT code, and there's been an increase in demand for people to learn the POEM technology, POEM technique, and there's been an increase in the use of the devices as well. And you can see that the reimbursement has gone up by about 60% since 2024. And more and more physicians are trying to learn this. I've been using the device since 2018. Why is the speedboat technology superior for you doing a POEM procedure? So this is a bleb, and that's a tunnel, and that's where you cut the muscle completely. So it's safer and easier to learn, as Rosen has explained to you earlier. It's got a protective stainless steel hull that prevents the deep injury if you need to protect the muscle. That's critical for ESD and even for the poem. You don't want to cut the muscle wherever by mistake. You want to cut the muscle intentionally. So the stainless steel hull actually protects the underlying muscle. Then the pain, due to the advanced energy and the technique that is used with the microwave, the pain that you get from the procedure from cutting the muscle is very minimal. That's why I'm able to send the patients home the same day. US health system definitely likes to send the patients home the same day. Every extra day in the hospital, you're given say you're given X amount of dollars for a procedure, and every single day you stay in the hospital is going to come out of that X dollars. So if you're able to send the patient home the same day, hospitals love it. So with the CPT code, so patients love it. Of course the patients love it, because patients are very stable. I've never had any patient coming back. Patients call me with chest pain. If they have any problems, they call me because I give my number to them, because I want them to feel comfortable that they have support. The other benefit is less device exchange, because this single device is able to do the cutting and the coagulation. Whereas when I used to do the previous device, I trained with a device from another company. When I started doing the procedures, we have to use multiple devices. So hospitals don't like it. In the US, definitely the hospitals don't like it, because every device is going to come out of the same X amount of dollars that being paid for the procedure. So less device exchange means the procedure is going to be quicker and faster and going to be cheaper. Because of the precision in cutting the muscle layers and preserving the muscle layers, there's improved outcomes. So less complications. You're not going to cut into the muscle. You're not going to cut into the lungs. It's very, very, very controlled treatment. And the localized effect, because of the way the device is manufactured, there is reduced thermal spread and less dispersion of the heat and improved safety. There's also one-to-one rotation, which is extremely important for the dissection. The advantages I have personally observed are that this enhanced safety profile prevents any heat spread, so patients are very comfortable after the procedure. Less charring, as was mentioned, because there's no sticking of the procedure, so that improves the visibility, because you need the visibility to be pretty good throughout the procedure. With the notch device that you can see here, with the notch you are able to notch onto the tissue, and that will significantly aid with the dissection. And you don't, previously we had to use multiple devices to actually hook onto the tissue and pull it back to cut. Whereas with the notch, the same device can be used, this notch part of it can be used to hook onto the muscle and cut it. And the predictable microwave hemostasis. So compared to the previous technologies, the monopolar technologies, with this, you are able to produce a uniform coagulation, uniform effect throughout the blood vessel wall, and very effective and predictable. So this study from this is a multi-center randomized controlled trial, which has basically shown that the vast majority of patients undergoing the POEM procedure using either a bipolar or monopolar technology, they were able to use just one device in 80% of patients who use the Creo technology or the speedboat, whereas 0% of the patients who underwent the same technique using the monopolar device, 0% actually use one device. That means all of them had to use multiple devices, every single one. So adding to the cost. This is a study from Roser, which was presented recently at the UGW, very recently, where she has basically shown that even with a single operator, even without an on-site mentor, she was able to produce very good results, even in the colon, which is the most riskiest area for doing a submucosal dissection. So very safe device, safe with beginners like me and with others. I train people to do this procedure. It's very safe to train, mainly because of the insulated hull and the controlled dissection. So why is US lagging behind the rest of the world in submucosal dissection and POEM? Mainly because of this lack of formal ESD training. Like, we don't go to Japan. There are some people who are able to commit and go to Japan for 6 months or a year. If that is available, yes, that is good. High medico-legal scrutiny, much higher than UK. So we are always aware of this. So I used to work in the university hospital. I used to be able to do more colonic ESDs at that point, whereas right now I'm working in a private setup. So it's like a large community hospital. We have research and we do a lot. I'm the one who does a lot of interventional endoscopy there, but still there's medical legal scrutiny. So the hospitals also, when you are going to the private sector, the hospitals also look at how much money you are able to bring in. The moment you get the reimbursement, moment you get the CPT code, the price goes up. Now, my hospital loves me doing POEM procedures because those pay. Patients love it. So previously I used to get patients being referred by other gastroenterologists for doing this procedure. Nowadays patients in the US, they research and they find that you do this and then they come to you. So the reimbursement challenge, the long procedure duration in the US. So US would love to have more procedure output. So you do 20 colonoscopies or you do one large colonic ESD. But this is going to change the moment you get a CPT code for the ESD. Poor reimbursement, staff, again, unfamiliar staff, that is same for any procedure. Surgical dominance in the GI neoplasia. Even now, in the US, most places, if you have somebody with a colonic neoplasia, they will be sent to the colorectal surgeons. So that mentality has to change, and it's slowly changing with the help of pioneers like Creo, by educating the physicians and the community. So the US market, there's a major opportunity in the US in the underserved ESD POEM market. The speedboat solves the barriers limiting the adoption, as we discussed now. And Creo can be positioned as a leader in third space endoscopy, as Carlos has already mentioned. Why is speedboat a breakthrough? The bipolar radiofrequency allows us to do a precise and safe dissection. The ultra microwave gives you a reliable hemostasis, and you don't, when you're having a bleeder with the other devices, if you're having a bleeder, you have to pull it out and get the new device to stop the bleed. Whereas with this, you are able to stop the bleed then and there. So the protective hull reduces the perforation risk, unless you really want to cut the muscle, in which case you just turn the device and then cut the muscle. So you won't accidentally cut the muscle. That's why we feel confident about training even your fellows to do ESD. The notch improves the traction, and fewer exchanges means faster procedures, means more procedures. So the market opportunity, the US, we do around over 140 million endoscopic procedures in the US. Over 150 million endoscopic procedures in the US. Not all ESDs and POEMs, but that's the total number. There's a growing demand for minimally invasive procedures, both from the patients and from the hospitals, because it's value-based payment is a system that's coming to in the US. If a patient is staying in the hospital for 5 days and has got more complications and is more expensive versus a procedure that can be done in 1 hour or 1.5 hours, and the patient is able to go home the same day on minimal pain medicines, the patient and the hospital would definitely choose that. I would choose that too. The dedicated CPT code for ESD, once we have it in 2027, I think, once we have the dedicated CPT code, it will standardize the national reimbursement and it will improve the insurance consistency for gastric and colonic ESD. So they will pay more, so more people will be convinced to doing it. And I would definitely be able to convince my hospital to doing ESDs. In fact, my first ESD in my private setup was a 12 centimeter rectal polyp in a physician's mom who was 84 years old, and I think we were there. I think the patient was able to go home the same day. She wanted to go home the same day. I wanted her to stay, but she went home the same day. No problems, absolutely no problems. So it's a very safe device, very safe technology, and it's a disease. It's a treatment. It's a technology that basically has got several applications, as was mentioned by Carlos already. So with the CPT code, it will dramatically accelerate the US adoption more than tenfold. So the economic driver, there will be lower cost, less length of stay, and attractive reimbursement. So to conclude, speedboat represents the next evolution in therapeutic endoscopy. There is no doubt. You've seen all the different possibilities. It's the only integrated radiofrequency and microwave in one device, with a traction notch platform. So it's a platform, not just a technology. It combines precision, safety, and efficiency, and it's highly scalable. It's steeper, smoother, and shorter learning curve. Because it's a safe device, she's demonstrated in the poster that it's very, very easily trainable and pretty safe for the patients. It's ideal for global expansion, ideal for training centers, and for clinical adoption. The evidence strongly supports its clinical value and its future potential, as we have seen. So the growth of the third space, growth of procedures happening in the third space is imminent. Speedboat is an ideal platform, well positioned to lead, and it's the right technology and it's available at the right time. So make use of it. Thank you.
Thank you so much, Ben. So I want to start by asking, does anybody have any questions?
So how many US doctors are likely to be trained by the time the CPT is launched, January 27?
This is just my opinion. There's approximately 150 different academic centers across the country. They all have fellowship programs, and historically they were teaching them how to do biliary stuff, EUS, ERCP. Now they all have to have resection programs, as well as large community hospitals. So everyone right now is saying, what is our resection strategy? How do I get fellows through here so we can make sure that we can control that patient? Because the patient, they want to keep in the health system because they make money for other procedures as well. So within the next couple of years, every academic center will have a program, and it will continue to grow, just like we're seeing at Dupont.
So I'd love to just take the pleasure of introducing Professor Pallav Shah. Pallav has been working with us for a number of years, also working very closely with Patrick Byrne at the back, Patch, lovingly referred to by us at Creo, by the team at the Royal Brompton and several pulmonology sites around Europe, and also by the team at Intuitive Surgical, who have been working alongside Pallav and us on the project with Microblade Flex. Just to give you a flavour of the people in the organisation, just going slightly off script, Patrick was a PhD student in North Wales under the tutelage of Chris Hancock, who sadly can't be here today, our co-founder, and he's been through his PhD and engineered and delivered the programme alongside Pallav and been to many of Pallav's cases, and has also been running the programme with Intuitive. So we owe a real gratitude. I'm grateful that Patch is here. More important to you guys is when you get to the end, feel free to barrage Patrick with any questions that you've got about how we got here and how we work with Pallav. But as I'd like to do, just hand over to Pallav and talk about some of the terrific results that he's had, and pleasure to have you. Thank you.
Great, thank you very much for the generous introduction. Basically, it's a privilege to be up here today to share with you some of the work we've been doing. In fact, you're probably the first people to see this data. It's not peer-reviewed and it's not public knowledge yet. So I'll just try and take you through this journey. Basically, what we're hoping to do is really transform lung cancer care. Now, just to put this into perspective, this is not a single tube. There are about 100,000 branches in the lung. So as lung cancers become more and more peripheral, this is quite a challenge to target anywhere in the lung in a very specific manner. So there are a few more issues that we face rather than just delivering an energy. Now, to put it into context, this is the data. And if you look at lung cancer survival, so approximately in the UK, we have something like 46 to 50,000 lung cancers each year. And unfortunately, we get about 40,000 deaths each year. So what does that translate to? The problem is that most of the patients, up until the last few years, used to present quite late in the natural history of lung cancer. If you put this on a global scale, there are about 2 million cases of lung cancer each year, and probably about 1.5 to 1.6 million deaths each year. So it's a real challenge. But what we've shown probably most successful in the UK is that lung cancer screening works, and if we find these spots early, we can make a huge difference. And this kind of illustrates this. And if you find a tumor that's less than 10 millimeters in size and give that patient the best treatment, the cure rate is 92%. But you can see it changes quite dramatically. If it drops to 21 centimeters in size, the cure rate's now 83%. If it's 30 millimeters in size, it's 77%. And if you've got any lymph node spread, it drops to about 50%. So finding it early is crucial, but if you can find it early but can't do anything about it, then again, what's the point? So really, this is really what we're trying to do, and this is the latest data from the US SEER database, and again, just reinforces that. It subdivides this into much more detail in terms of size, but the clear message is the earlier we find these lung tumors, the more we're able to do for them. So you've all seen this setup so far, ultra high frequency microwave energy, and in this case we're using it slightly differently to destroy tumors. So we're not doing any dissections, we're basically placing this in the center of a tumor and then ablating it. And here's one of our early patients. This patient actually had chemoradiotherapy for lung cancer. They were under follow-up, and if you look at the area up here, you can see a little spot growing up. So this is within the field of the chemoradiotherapy. So this patient couldn't have any more radiotherapy, and normally they would just have systemic chemotherapy and it'd be palliative. But what we did in this patient, and you can see again, the PET scan just highlights that it's very active and therefore likely to be recurrence. We didn't know it was recurrence for sure, but this is the procedure we do. So essentially, we map up the CT scan from the patient, we match it to the patient. The way we do that is by driving the robotic catheter into the various aspects of the lung. And my left hand essentially moves the robotic catheter forward, my right hand can move it 360 degrees. So literally I can go anywhere in the lung with this. And we're going to about 70% of the depth of the lung in each area to synchronize the CT that we've got before the procedure with the patient. And once you map out all those areas, you can see the blue light coming on, so you map that area of the lung. And once you've mapped all the areas of the lung, you've essentially synchronized that imaging. And then becomes the navigation bit. So once you've synchronized it, it's a little bit like GPS in our car, and what we do is we follow the blue line. So we now stop using our brain, we just follow the blue line, and makes life so much easier when you're trying to find 300,000 branches. So basically it's cut down the procedure time quite dramatically. So something that would take me 30, 45 minutes, now it takes me a minute and a half to do. So basically it takes me 1.5 minutes to get to the lesion, and like every good video game, you get a nice target showing up when you're in the right spot, and when you've got your target in line, what we tend to do is we can either put ultrasound or various tools in to see if we're in the right spot, or even better, we've got a CT scanner in our bronch suite, and we perform a CT scan, and in 5 seconds I have an image which tells me where I am. So we've segmented this nodule there, and we can see the robotic catheter, and when you look at it in 3 dimensions, you can see I'm at the exact correct spot in line with the spot. And then once I'm there, I can then throw in different tools. I can biopsy this lesion. That's a needle going into that area, so we're making kind of pilot hole into it. Then I'm going to put an ultrasound probe into it. So this is, actually this is a cryo probe, so this allows me to take a biopsy, and this is an ultrasound probe that tells me I'm dead center in this lesion. So I've got central strike, and then the next step is for me to then double check very quickly while we're still doing the procedure. Under the microscope, you can see there's clearly cancer cells there, so there's no questions for me. In that same procedure, I'm going to destroy this tumor. So we then put in a microwave ablation catheter, the one you'll see with Patrick on the desk. Here's the microwave ablation catheter in the center of this lesion, and then we withdraw the robotic catheter away, so the microwave catheter is exposed so that it can deliver the energy without any interference. And so this is the microwave catheter just being gradually withdrawn. And then once I'm in the optimal position, we also then can check with that CT scan, we can segment the lesion, we can put a tumor margin around it. So here's us segmenting the lesion, we put a tumor margin in it, and then we can also map the ablation zone. And if it's all green, we know that I'm going to adequately ablate this tumor. If it wasn't optimal, I could reposition, or I could take the decision to do one ablation there and then in an area where I think the ablation wasn't performed. And this ablation process takes a whole of 3 minutes. So, and not only the advantage of 3 minutes compared to all other technologies which take a minimum of 10 minutes, is I can then do it in a breath hold. If you do it in a breath hold, you get very precise ablation, exactly like you want it. Plus, the catheter we use is the high frequency one, and with this combination, what we're getting is almost a surgical precision, 28 millimeters every time in a spherical view, as if you've just cut out that lesion. And this is pretty consistent. So this is 24 hours after the procedure. You can see you've ablated the lesion, and then you can follow it, and you can see this is day 1, this is 3 months, it starts to shrink, 6 months, it's even smaller. And if I show you other lesions, just to get your eye in, you can see when you first treat the lesion, it's actually going to get bigger, because you've heated that area up, you're going to scar the adjacent lung, and then over time, you can see that it's shrinking. And in all of these, you can see all of them shrinking. And this is the kind of pattern we get. Now, this is, obviously I don't expect you to read this, but this is just to highlight to you that very systematically gone through so far 35 patients in this particular trial. This is a trial where we treat these patients. Most of them are either not fit for surgery, so they've got emphysema, cardiac disease, multiple comorbidities that makes them unsafe for surgical resection, or alternatively, there were a few patients that actually vehemently refused surgery but did accept this modality, and then there were a few patients who had metastatic disease from other sites. And then the plan is just to follow them over time and see what happens. This table shows you quality of life. So one of the most striking things is that if you do surgery, all the patients have a blip in terms of their quality of life deteriorates and then improves over time. If you do radiotherapy, it's the same scenario. They get esophagitis, they get pneumonitis, they can get rib fractures. Transthoracic, so putting a needle in from outside with microwave energy, has been around for almost 10 years. Those patients stay in hospital for about a week. They have pain. They're on a patient-administered anesthesia, so they're giving themselves shots of morphine literally every 4 hours. In contrast, these patients go home. We keep them in overnight at the moment just as a precaution, but technically none of them have had a flare-up or any significant adverse event, and I could send them home 2 hours after their procedure. Sorry. So this is just to try and put into context some of the adverse events of transthoracic microwave ablation. So when you put a needle in from outside, you'll see death rate of around 2%, pneumothorax, so a punctured lung, in 33% of patients, 34% of patients, fluid, almost 10%, hemorrhage, 2 to 34%, fistula, which is a hole between the lung and the lining of the lung, again, quite a significant morbidity, 4%. Air embolism, so if you get an air embolism, that's air tracking in from the vasculature, can travel to your brain and cause a stroke. It can go to your heart and cause cardiac arrest. That occurs in about 1%. And then infection and post-ablation syndrome. Now, this is actually based on well over 3,000 patients treated. So we know that their data is pretty robust. We'd like to get there, but in our series of patients so far, the order of magnitude of these events, you can see, is completely negligible. We had 3 pneumothoraces. 2 were due to the biopsy that I did before I ablated. 1 was probably related to the ablation, but again, that translates to a 3% compared to 33%. Local recurrence has happened in about 4 out of these 30 patients, but like I said, we can retreat those if appropriate. But actually, most of these patients, when we've dug down to them, actually had fine metastatic disease that we couldn't see at the time of treatment. So they had small nodules in multiple areas. So some of them had nodules gone to the liver, some of them had brain metastases and lung metastases. So probably they were not suitable for treatment, but at that stage we didn't know that. There was 1 death in the study, which I think, I may be biased, I don't think it was related to the procedure. It was essentially a patient with emphysema and COPD. He went to his local hospital about 10 days after the procedure with the exacerbation of COPD. He had carbon dioxide retention. So if he had come to our institution, we would have put him on non-invasive ventilation, tided him over that acute stage, and he would have been fine. He saw a nihilistic physician who basically put him on a morphine pump and allowed him to die and gave him no intervention at all. So I'm kind of upset about that, but I think on balance, I'm not sure that it was related to the procedure. But obviously, we're transparent, so we report everything. Now, one of the unique things we've done in this study is half the patients had a biopsy and ablation in the same sitting, something that's actually almost thought of in the medical world as a fairy tale. Normally, you'd biopsy it, know what you're dealing with, and then treat it. But what we've shown is whichever strategy we use, there's no difference in the outcomes. But in terms of patient care, this means a lot. Because if you look at the lung cancer pathway, for example, an average patient in the UK, it takes them about 3 weeks to go from the GP to the specialist, then to have scans, then to have diagnosis. Guess what the average time after their journey started do they get treatment? Any ideas in this room? About 120 days. Now, we can do this. If we use this kind of pathway on a larger scale, you could treat these patients, you can diagnose them and treat them and even stage them in the same sitting. So you can, and the procedure itself, like I showed you, takes about 30 to 35 minutes. So you just imagine, compared to surgery, how much more we can transform this. But let's just slow down a bit. At the moment, we need to build the evidence. The evidence so far we've conducted is in patients who are not fit for surgery. Surgery is still the gold standard. It will remain the gold standard until we can accumulate a lot more evidence. But this shows that this is a modality that has several serious leverage. So this is a 1-year survival curve. You've got radiotherapy or SBRT in red. You've got surgery in blue. We were doing quite well until one patient got a recurrence. So you can see that disease-free survival or recurrence-free survival at 12 months so far is following the lines of what our traditional modalities are. We just need to prove this at a large scale. But not only that, we are at the moment doing a study where we treat the patients, but then a month later they have surgery. That means we can actually genuinely evaluate, are we actually treating the lesion in the same way we think? So are we treating every single lesion 28 millimeters every time? I think we are, but we need to prove it. So there are a number of studies we need to do before this becomes mainstream, but you can see that if something like this works, it's going to completely transform care from what we're doing at the moment. And maybe other dilemma in medicine is that we find these nodules, but not all of them are cancers. So the normal strategy is let's just do another CT scan in 3 months. We'll do another scan in 6 months. We'll do another scan in 12 months. But now what we can do is we can actually completely change that paradigm and make it so that we're doing a diagnosis much earlier. And in those with early diagnosis, you could have this option, or you could have conventional surgery, whereas otherwise, in more advanced disease, you really can't have this kind of curative approach. So I'll stop there and take any questions. Thank you.
I've got a question, Paolo. So screening doesn't make any sense to me, at least in the US, how they do it. You have to be smoking for like 30 years before they screen anybody. And is it because there's been no therapy to deal with these small nodules that hasn't caught on?
It's quite complicated. I mean, the big problem with lung cancer is that it does tend to be very indolent and only causes symptoms when it's much bigger. And by that time, it's too late. So clearly, we have to find it early. So screening is very important. I think the problem with screening is implementation. And in most of our economies, usually the people who come for screening are the people who least need screening. But the UK has been very proactive on this approach. So what we've done is actually we send these mobile trucks with a scanner in it to the shopping malls and the shopping centres, and people are given questionnaires outside, and it's a captured audience that say, okay, I'll go and have this scan. And in fact, in the last year, through screening, we have detected 5,370 new cancers. And the interesting thing is most of these cancers, 90% of them, were in the very early stage, sub 15 millimeter nodules, compared to the normal scenario where more than 75% of the patients we see are with advanced disease. So screening is the way forward, but we need to implement it properly.
Prof. Shah, so we can see from the data that the ablation is reaching the same recurrence rate as the standard of care, either SBRT or surgery. Talk to us about what the implication of that is to a patient who would have otherwise gone for surgery or SBRT.
I mean, again, I would re-emphasize that the gold standard is surgery. So even I usually advise my patients to go and have surgery. But what this shows is that those patients who are not amenable for surgery already have a treatment option that gives them outcomes similar to surgery. Now, let's say all of this, what we've shown, stands out in 5 years' time to be absolutely robust with no change. Then I think patients will vote with their feet. They don't want a lobectomy. They don't want to be breathless afterwards. They don't want the chest pain. And I can see that some people will insist on having a non-invasive approach. And in fact, many of you in this room might be familiar with the really fancy term of NOTES. And NOTES was very fashionable at one stage. So this is native orifice transendoscopic surgery. But no one's actually ever done NOTES. I think this is as close as it gets to NOTES. And what these guys have shown us is what's as close as it gets to NOTES. And that's what we're going to see in the future.
Thank you. So this audience will well know that we're working with Intuitive Surgical to bring the combination of a robotic technology and ablation to the market. Talk to us about why Intuitive have picked Creo to deliver the ablation technology.
Well, I think ablation thus far has been a bit of a difficult area. I mean, the FDA had some troubles with ablation. And partly it's, if you use the wrong approach in the wrong patient, you're going to get the wrong answer. So what was clear to me was precision. So all the other companies are out there saying we want bigger and bigger ablation zones. So, there's one company out there, minimum of 30 millimeters. There's another company out there saying, no, we want 50 millimeter ablation zones. So, but big is not better, because if you're bigger, you're more likely to hit vital structures. And it's when you hit vital structures that you get bleeding, hemorrhage, pneumothoraces, all these other complications, cardiac inflammation. Whereas our philosophy, and I'm happy that I managed to convince Chris Hancock, Patrick, and the team, is that we want precision and reproducibility and consistency. And we've settled for what everyone else considers to be suboptimal, an ablation which is 28 millimeters. But it's not inadequate if we're going to target the right patients, which is on the whole sub 20 millimeter lesions in the early stage. So I think, and then if you marry that up with Intuitive's technology, where we've got such good precision, I mean, I showed you for that reason a 4 millimeter nodule. If you can get to a 4 millimeter spot in the lung, which has got 300,000 branches, and then biopsy it, prove that it's cancer, and destroy it at the same time, you should be able to do anything.
Thank you. Any questions from the audience?
Sorry, you mentioned that the first study, is that the UK study, 30-man?
Yeah, so this study, which I've shown you the data for, is the UK first-in-man study. To be fair, 34 patients have been done at our centre. One patient did get in from the Netherlands.
Right, because there is one going on in the Netherlands at the
So
Amsterdam Medical
that
Centre.
ongoing study, again, is a multi-centre study. It's occurring in the Netherlands and with us, and that's the treat and resect study. That's the one where we are going to treat the patients, and then we resect the tumour and see that we've reproduced what we think we have.
And how useful is the first study going to be, given that there are multiple comorbidities with most of the patients? Are you going to be able to have a control group that will be useful?
As you said, it's the first-in-man study. What you're trying to show is that this is having an effect in a group of patients which is similar to an effect in patients who are otherwise going to be able to have surgery. So it's treat and follow. And the beauty of it is that these patients are all no-hopers. They have got no other treatment options. So if you can make a no-hoper live 2 years, 3 years, you've already got a win. Yeah? You do not need to match surgery. You just need to show that in this group of patients where the mortality is, well, the survival is 9 months, usually. If you've got a disease that you cannot treat, on the whole, your survival is somewhere between 9 months and 3 years. So the 3-year data will be really important, but we're already getting a signal that this group of patients are doing relatively well than if they didn't have any treatment. And we have to build the evidence base quite carefully. The gold standard is randomized control studies. But the problem with this kind of technology is that if you look at Sabre tried to do a randomized controlled study with surgery, but patients vote with their feet. They all wanted Sabre, so they really couldn't then recruit to the surgery arm. So it's one of those things that's very difficult to study. So that's one of the reasons why, one, we want to build evidence in people who have got no other options, but two, also match it with data that shows us that in patients where you've done something, you can then take the cutout out and just double check that you've done what you've said. In fact, there is no evidence in any radiotherapy literature where they've treated a patient and then done a resection to check that they've done what they're meant to do. So although it's not randomized control evidence, I hope that collectively it's building an evidence that's more compelling.
Intuitive have just received some FDA approval to work with lung biopsy procedures, in fact, as early as last month. So when you've given them sort of a rough outline of what's being achieved here, they obviously don't have the flexible extension capability of Creo. How do you see a regulatory pathway to them being able to use this type of flexible addition to their armory? And in terms of clinical trial pathway, obviously you refer to further trials being required, obviously, but what sort of regulatory pathway can you see in terms of time to bring this to market? Thank you.
Well, I think we're quite lucky in this field, really, because if you look at all the microwave ablation devices out there, they've all got what we call 5K10 approvals. So if you can show that works in soft tissue like liver, kidney, then you can virtually apply it to the lung at free will. Now, we've done a lot of these cases with Intuitive's robotic platforms, so although they did not have the relevant licenses to use it in a clinical trial setting, we've proven it. And in fact, since this trial finished, we're now doing what you would consider commercial cases in London, which are not part of a trial in patients. So I think the same will apply in the US, but they probably know the regulatory pathway better than I in the US. But once we've got enough data showing that in humans it's safe, then animal data will show the efficacy of it in terms of it does exactly what we said it would. Then you add on our treat and resect data, I think it'll form a very compelling evidence that even the FDA should start then changing their view on ablation.
If I can answer on behalf of Creo. So in Europe, we have free license to market the product under MDR, so Palab, and doctors from other countries can get their hands on the product, and they are doing so. We're moving into the Netherlands, as the audience member mentioned earlier. We're also moving into Switzerland and into Italy in the next few months, as well as adding new sites in the UK. When it comes to the US, there were a couple of patient deaths for a competitor product, which did get onto the radar of the FDA, and they put out some guidance, very public guidance, around the pathway for ablation products in the lung. We have a 510K for the product, which means it can be used in soft tissue, but unfortunately it's restricted to open use and not down an endoscope in the US for now. But this study was designed with that in mind. It will be taken to the FDA once we get to the 12-month time point, with a view to applying for a breakthrough designation and a de novo pathway. That means we will need to do a study. But the plan using this pathway is to reduce the burden on Creo, on the doctors in the US, to generate that data to convince FDA for the approval. So our aim is using this data to take the least burdensome approach and pathway in the US.
So the ongoing trial would then take de novo 2-3 years?
So our estimate is that we would take the ablate and follow data, which will be complete at the end of next year, to the FDA for a meeting, a pre-sub meeting it's called, in the first half of 27, with a view to starting studies that year. The studies themselves will take 2 to 3 years. So we are a few years away, but there is a clear pathway for this product to reach the US market. And in the meantime, of course, Intuitive are building a very strong and large footprint of ion robots across the US. So once we get the approval, we will have a very open and large market to tap into.
Hi there. Just a quick question around the increase in use of cancer immunotherapies in resectable lung cancer. I mean, there's several new treatments now which have been approved perioperatively. So how are you thinking about integrating those into future clinical trial design?
Yeah, that's a really good question. I mean, I think cancer treatment as a whole is becoming much more of a hybrid multimodality treatment. If you look at colorectal cancer, if you look at breast cancer, it's a combination of neoadjuvant chemotherapy, immunotherapy, surgery, and radiotherapy, and then quite often oral drugs afterwards. And I think so far in lung cancer, what we've seen is that if it's very early, less than 10 millimeters, then the gain of adding in adjuvants is not that much, because adjuvants usually get you somewhere between 6 and 8% extra. And if you're already at 92%, you're never going to get more than that. So I think it's more the role will be in tumors greater than 20 millimeters probably. And if you look at trial design, so there's more and more trials coming up where you're looking at arms such as surgery versus surgery and immunotherapy. And I think we could do something very similar, which is ablation, immunotherapy versus ablation alone. But there is also a possibility that we could do trials in the future where you're doing ablation and immunotherapy and then surgery to really, in that 84% group where there is a tumor bulk. And there is some evidence, but I think people talk about it, but no one's generated the level of evidence that would satisfy me and a few others in this room of so-called abscopal effect. So what I mean by that is if you destroy a tumor, if you're cutting out a tumor completely, you're really relying on just the odd cell being around, but on the whole, you don't want that odd cell being left in the body. You're literally removing the antigenic stimulus completely. So the theory is that if you ablate the tumor but don't completely destroy the proteins, then those proteins will go and prime themselves into the immune system, and you're potentially looking at vaccinating the patients against their own cancer. There are a few things Patrick and I are playing with which might make that a reality in the next 5 years, which I can't really talk about at the moment. But the principle is that you're going to treat the tumor in such a way that it releases the antigens into the immune system and vaccinates the patients against their own cancer. And then just to be double sure, let's cut it out and be sure that it's gone, or destroy it with microwave completely. So I think that's where we're going to go next.
Thank you. A numbers question for you here. If you look at all the new cases of lung cancer in the UK on an annual basis, what proportion of those would be relevant to Creo's treatment? And if you manage to get the required evidence to roll this out, to become the gold standard in this sector, how long do you reckon that would take?
So in terms of numbers, I mean, the big problem with numbers at the moment is that we're not seeing enough early curative disease. So I think the numbers are going to change over the next few years as lung cancer screening becomes more and more established. So the primary problem globally is that the vast majority of tumors present in advanced disease. So we're therefore restricted to spending hundreds of thousands of pounds on chemotherapy and immunotherapy. Yeah, that's the reality of it. The patients for surgery or for Creo's devices are a relative minority. But lung cancer will help, screening will help us shift that. But not just lung cancer screening. I think the intuitive platform, which allows us to biopsy these lesions much earlier, will also increase the number of people who will be amenable to curative treatment. And then the second group, which is actually a bit of a magic box because it's very hard to quantify, are the patients with metastatic disease. So, melanoma mets to the lung, like I show you, breast cancer mets to the lung, colon mets to the lung. So these metastases normally wouldn't really be treatable. Some will have surgical resection, but again, you've got 5 different nodules in the lung, and you have surgery to try and take out 5. That's quite a burden on the patients. So that's a huge market for this kind of therapy because you can just do 5 local ablations and then complemented with chemotherapy. So I think the metastatic disease market is big and that's ready to grow today. The lung cancer market will be slower and maybe take 5 years to really catch up. But I think it's going to be an exponential curve. But that's about right. I wouldn't want to see this taken up too quickly without building the right evidence. We want a robust platform before we build on it. We want to we want to show that it's safe in multiple hands and then grow it steadily.
Time for one final question.
I'll take it if no one's there.
Come on, go for it.
In terms of, it's important to get it early. Using proteomics, it really does help narrow down patient populations potentially. And I've seen some fantastic proteomic opportunities. Are there any technologies you think would work well aligned with this potential technology?
Yes, you'd really talk about different ways of screening early. At the moment, we use CT scans, which obviously needs radiation dose, needs someone to physically have it. It's much easier if you can do a blood draw and be confident about that. I mean, that area is evolving very rapidly, and we've got even high-sensitive circulating tumor DNA, which is what you're talking about, and that is becoming helpful. But again, that's going through the evolution. It's got false negative rate. It's not picking up all tumors. You're relying on the tumor actually shedding cells. There are some types of tumors, particularly what we're seeing in Asia, which are adenocarcinomas, which don't tend to shed cells. So it's a complex area, but it's going to add to our armory, is what I'd say.
Thank you, Prof. Shah. I mean, I'm very close to this technology, and it blows my mind every time I hear him talk about what he's doing at his centre. Thank you.
Forgive me because I have to apologize.
Thank you once again. Okay, we're on the finishing straight. So I'm going to talk to you all about how we're going to go from specialist innovative products through to broad market adoption. As the person alongside Kate here, who's been responsible for organising this event, I want to say thank you for coming. It's gratifying to see so many people in the room. I also want to thank everyone at Numis and at Walbrook for making it possible, and to Kate for putting in all the effort to do the logistics and to make sure that the AV was working and to have everyone's presentations fit and ready to go. So thank you. So it's my distinct pleasure as Chief Product Officer at Creo to be responsible for product development, because we do some really cool stuff at this company, as I'm sure you'll all agree, having heard these talks. Our focus to date has been on specialist innovation. We've created some very highly innovative products to meet high unmet clinical needs. But that's a niche market because it's all a growing market due to earlier detection of disease. We are evolving as a company, and I'm sure many of you who've been tied to this company over the last 10 years or even longer will have seen that change. 3 years ago, we had one product serving one indication. Today, we have 8 products on the market serving multiple indications. And that's that's all down to our adaptive multimodality energy platform. That gives us the opportunity to target multiple therapeutic areas across the whole spectrum of therapy. Creo is powering the next era of endoscopy, and I'm going to show you how. I've got 2 minutes and 2 slides to describe our whole market, which I'm sure Chris Donnelly, who's in the room, will agree that's not an easy task, but I'm going to try. So, let's think in twos. We have 2 technical verticals at the company. We have resection and dissection. So those are the tools that Rosa, that Ben, and that Carlos use in the GI tract to either treat cancer or disorders of the GI tract. And then we have ablation, soft tissue ablation. That's EUS-guided ablation with microplate fine, or the lung ablation we've just heard about in the lung. Then we have 2 clinical verticals. That's the treatment of cancer and then the treatment of disorders. So they are distinct. One is to cut and remove suspicious tissue that could either be a lesion suspected of being cancer or an actual cancer. And then we have treatments for disorders. And this is a rapidly growing area of therapeutic endoscopy, as described by Ben. More and more people are having swallowing disorders and problems in their upper GI tract, which need treatment, and the reimbursement for those procedures is growing. And then the other 2 verticals are the specialties that we address. So we do work in the GI tract, and we have an active commercial channel that we operate at Creo ourselves to exploit that field of specialty. And then, of course, we have the lung specialty, which is addressed through the relationship with intuitive surgical. But underpinning all of that is one thing that unifies everything, and that is our energy platform. So Creo is not a device company anymore. It's a platform company. It's an energy platform company. And we are going to change the market in what we deliver. So the markets that we address are not static. They're growing. And that's, as you've heard today, because detection is happening earlier and earlier through screening programs. So everything that's happening in the colon, or has happened over the last 10 years with screening and the detection of polyps earlier, is going to happen in the lung over the next 5 to 10 years. That means our SAMs, our serviceable addressable market, are growing rapidly, and we are providing all of the solutions to address those markets. So each NPD, so each new product development that we undergo, each new product that we bring to market is incremental growth. Why is early detection important? So early detection in cancer means that we find smaller polyps and smaller suspected lesions earlier, and that means endoscopic treatment becomes more viable than surgery. And Creo is uniquely positioned because we're the only company who can get bipolar RF and microwave down a long, thin catheter. Now, trust me, that is not an easy job. And I'm responsible for product development at the company, so I live and breathe that, as does Patrick, every day. It is not easy and no one else can do it, but we have been able to do that. And we've got 8 products on the market that prove that we can deliver these novel technologies to support the treatment of precancerous early polyps and lesions. So we have 2 critical success factors that will drive the growth of Creo in the future. The first is positioning our energy platform versus everything that's come before it. Now that's quite easy in endoscopy because everything that comes before it is monopolar RF, and we've been using, well, doctors like these folks here have been using monopolar RF for decades. It's an outdated technology because it doesn't control where the energy is going in the patient. There's a risk of secondary sight burns. It really is a decades-old technology that is ripe for replacement. In surgery, where we hope to expand into, there's been bipolar RF and advanced energy for a while now. The key to success for Creo will be carving out a new category of energy on the market. Our adaptive multimodal energy unlocks new endoscopic options that weren't there before. we are more controlled and confident in how the energy is applied in the anatomy. As we've heard before, there's reduced need for device replacements and swap outs, which saves time and makes procedures more efficient. Ultimately, we're providing a consistent future-proof energy architecture that doctors like these can rely on. The second critical success factor is creating a portfolio of products that meets all of the needs of our doctors that we serve. Now, for a company of our size, we have I would say, invested our time in understanding what is needed. Last year, to give you an idea, we spoke to 182 doctors in the US about what they value in endoscopy from their tools. We also spoke to them about what they need in the endoscopy suite. So when we develop these products, we don't do it blindly. We invest a lot of time in understanding how our return on investment will be met. This is the product suite that we know will round out the needs for more than 90% of procedures in the GI tract. What this becomes is the silver bullet that we need to replace Hervé as the chosen platform within GI endoscopy. So, as you can see, we're transitioning from a product company with unique, innovative products to a company with a full energy-based platform and a full suite of products. In the next 2 years, we're going to be launching 4 new GI products to cover all of the needs of endoscopy. This means that we're accelerating our sales trajectory. We're going to be covering 3 verticals of clinical expertise, which includes GI, HPB, and lung. And we're going to do this by outsourcing our product development with partners who have got expertise in manufacturing these products at low cost. That means the speed to market, the cost of the development, and then the price sensitivity of these products in the market can be managed very closely. So, as I say again, in the next 15 to 18 months, we're going to be launching 4 new products, which will massively increase the volume of products coming out of our company. So this is truly underpinning our ability to become an energy-based platform. I'll now hand over to Rich to cover the financials.
All right, well, apparently I finished about 20 minutes ago, so... was I needed a clicker? Here we go. Okay, so if you go back... Can I go back with this? I'm just going to quickly go back to a slide that Charlie put up. So what we do from looking at our available markets, and stand back a bit so you can see the slides. In terms of total available markets, Charlie said we look at different verticals in a different way. So we're looking at whether it's cancerous, so whether that's then esophageal, stomach, and colorectal, or then it's ablation using lung and the pancreas, liver, kidney, or we look at the disorders that we have. We've looked and analysed what the size of the markets are in total, what the size of the markets are that we can go after, and we've looked at it when you have the full suite of products available to us. So the full suite of products will be available to us by the end of roughly 2026 into 2027. So the sales teams you see in the room today and the rest of the sales teams we've got around the world will have all these at their disposal to sell. Over the last 12, 18 months, they've had more and more products available to sell into the market. So what you then look at and see is that when you break down each of the GI resection for cancer and ablation for cancer and the GI disorders opportunities, you're looking at very big total available markets. Yeah, lung cancer is a huge market. But if you're looking at the market that we can go after, the way we looked to quantify it, you're talking of, sort of roughly $1.5 billion market right now, growing over the next 10, 15 years to somewhere near sort of a 4-ish billion market by the time we get to 2050. Not sure any of us are still going to be around in 2050, but what we're going after, if I can, What we're going after right now is that 1.5 billion or roughly billion market that we can target with the products we got at our disposal when we've got the full suite. So right now we need to build the sales teams, build the sales channels, and build the clinical evidence to go after this. For those of you that have been with us and seen the journey from a long, long time ago, Kevin's mentioned already at the start of his speech that we've hit our targets since the middle of 2024 onwards. We've seen a growing evidence of a growing trajectory in sales quarter on quarter when you take the line through it. We expect to see this continuing and continuing to grow. We've grown year over year. We've grown roughly this year, we'll grow 40 to 60%. See, Duncan said that. We've got to grow at roughly 40 to 60% this year from a revenue perspective. We expect that to continue to grow. We're not going after a 1.5 billion revenue line in the next few years. We're going after a very, very, very small fraction of that number. So execution from the sales team, execution internally, execution on having the products available is absolutely critical to what we're trying to do. But at the same time as growing the revenue, we have been taking our costs down, quarter over quarter, year over year. The reason that this can happen at the same time as growing this is we've invested in our sales team 12, 18 months ago. We have the sales teams in place. But also what you see at the back of the room, we've done the hard yards. We've got the evidence. We've done the R&D that we need to have done to the products. We've got the regulatory clearance. Charlie's just said when you look at the extra products that are coming online, I know I'm switching around a bit, but you look at the extra products coming online, these are outsourced. We're not incurring additional internal cost to produce these products. So one of the challenges that we've had for a number of years is a cost base that was relatively high versus what our revenue lines were. What we've done over the last year and a half, 2 years, is take that cost out. Will that cost come down slightly further? Possibly. But what we're not going to be doing is adding a huge amount of cost into this line to facilitate this growth. We do use distributor networks in Latin America, in APAC, now in Europe through Creo Medical Europe, and that's to develop the markets that these guys have already talked about and the potential size of the markets that are going to come in those areas. This gives a little bit more granularity as to the size of the markets in each one and how they're going to grow. You know, so there's a significant growth from 2025 all the way up. You can cut and slice and dice this number all you want. You can look at cancer incidence rates. You can look at what we expect, the volume of in terms of screening, et cetera, it'll come in, and every single metric will tell you that you're going to see more and more cases that will need to be attacked and need to be treated. The focus from us, though, over the next few years is we are going to grow. We will grow our users. We're going to grow users. The fact we're going to grow our revenue. But what we need to grow is utilization per user. When we first set out the model back in 2016, we said that if one user uses a product twice a week, it's a $100,000 account. That's all well and good. They're $1,000 a pop, but the lung device is not. The lung device is over £5,000 per device. So you don't need as many people to generate 100,000. Or, if you think of it another way, 100 cases a year is $500,000 if you're talking about a lung product. If you're talking about a spider blade, it's close to 200,000. So the more you can drive growth of utilization per customer, the better you are and the more revenue you're going to grow. We've got roughly 250 users right now. Yes, this says we're going to grow to over 800 users in an unspecified time frame. I'm not allowed to put a forecast on. But the key is driving utilization per user. If we can get every user of the 250 to use it twice a week, it's a massive difference to us as a company. So you will see the revenue from Creo keeping on growing. You will see it growing in the next few years at roughly 50% growth year over year. We expect to, at some point, be shooting the lights out of that number. And you will see the revenue grow to beyond 20 million, 30 million, 40 million. But what you've got as a cost base right now is roughly high teens millions of revenue is a break-even position. We're not far off. It's a few years away. But the potential that we've got in the lung products, in the pancreatic product, in the colorectal product, in the POEMS product, and all the other products we've got go way beyond that 20 million. I'm happy to read questions right now, or you can wait to the end. I'm happy.
Hi, what's your position on cash and cash flow break even?
So cash today is sort of 15 million-ish, thereabouts. Cash flow break even is that sort of high teens in revenue. So you get a high teens in revenue with a cost base of sort of middle of teens with the profit we get from the business plus contribution for the business that we own in Europe. It's sort of high teens break even revenue.
And when do you expect that to be achieved?
Second half of 2027 into 2028.
So do you have enough reserves to take you through to that?
We have enough reserves to take us through to that.
Yeah.
There are certain decisions we have to make as a business to get there, but we've got the levers inside the business to get there.
Thank you.
How should we think about the cost of clinical evidence generation for this partnership with Intuitive? Is that something that you guys have taken into account?
Yeah, actually, so the total amount of cases that we need to do for Intuitive purposes is around about 100, 120 cases. So our cost of that is providing the devices for those 100, 120 cases. The device cost, as long as I know Intuitive people or people in here, the device cost is not huge. It's probably our cheapest device. It's got less moving parts and less parts in the actual device. So then it's the cost of those 100 devices roughly plus time of somebody to be at the cases. So that's our investment. It's not a huge investment for the size of the pie that's there at the end of it. The actual cost of the ION platforms and all those things, that's not ours.
Hey, Richard. Just a quick one on, we haven't spoken much about other licensing opportunities. I think you kind of defocused or deprioritized that at the interims. But maybe just thinking more blue sky, any sort of thoughts on sort of further partnerships down the line, robotics, etc.?
Yeah, so a couple of years back, we invested in our robotic potential. That robotic potential is on vessel sealing. So it's taking the spider blade product and turning it into a vessel sealer for robotics. We've done that, and it's on the shelf. We were talking heavily at the time to Intuitive for the Da Vinci platform. We are still talking to Intuitive. We are still talking to multiple other robotic companies. There are many, many robotic companies out there in the world. All of them want to compete against Intuitive. So it's not gone away, but what we've not done is put it in the numbers.
And Microtech, any comments there? I mean, China's also, I assume, not in the numbers either, is it?
China's not in the numbers. We're not. We will go into China. We will get clearances in China. We've not anticipated them in the next few years for sure. We are working with Microtech to develop one of the Grasper products you'll see at the back. Lewis could definitely answer how his relationship with Microtech is going on a day-to-day working basis, a lot more than I can. But in terms of the performance from Lewis's business, Lewis is at least in line with budget for this year and probably slightly ahead of budget. So from a relationship point of view, we've still got a lot of control of to what happens in Europe because of Lewis. Lewis is our designated guy on the board. We will be spending money over the next few years, probably not in the next sort of 6 months, but in China to get our products developed. And we are actively working with Microtech as to what do they want to see in China, what type of platform, what type of devices, etc. I think we'd rather go into China with a known quantity rather than somebody we have no relationship with. Thanks.
Yeah, hi, Colin Smith from Capital Access Group. I've never encountered the company before, so this is all new for me, but I thought it was interesting listening to the eminent speakers you had talking about the medical challenges, because it sounded like in terms of a financial performance, there was a lot to do, or perhaps quite an issue, around how quickly the medical establishment actually gets familiarity with and begins to take up your product, and that wasn't really covered in your discussion there. It sounded like a sales program rather than a how do we get everyone to take it up and use it 2 times a week or 3 times a week or 5 times a week.
Yeah, so it's really easy for me to say use it 2 to 3 times a week, isn't it? It's quite simple maths. I think 2016 is when we started the journey. We had no products qualified at that point in time, or no cleared products. You're now looking 10 years on, roughly, from that point. So there's a lot of history around how do you train, a lot of history about how do you get adoption, We've made mistakes in the past around going after certain doctors that were never going to adopt it, or there was challenges with the hospitals that were not going to adopt the product quickly. We've learnt an awful lot in 10 years. I think you've got a team now that understands how to get things into hospital, which doctors are going to continue to use, which doctors are not going to continue to use. We do training before they get into the animal labs. We do benchtop training. There are certain doctors who are rock stars and don't even need the animal lab training. They just go straight in and use it. I think we referenced at least one of them today. So I think it is not an easy road. We're not going to, grab somebody and make them use it twice a week just because it's a product they should be using. Rosa's slides were showing how long it took her to start to go to where she is today. There's a lot of hard work and effort by these guys to mentor and train the people to use the product. Every day it's blood, sweat and tears internally to make sure that we're hitting the relative targets and getting more and more people to use. I suppose I can hand it over to Dave. He'll probably give you the blood, sweat and tears and the blocking and tackling. I've heard that a lot, Dave. Do you want to make a comment?
I mean, the hurdles to bring innovation to the marketplace are a couple, and we had to kind of go through those. Reimbursement that we talked about early is huge. And the fact that we're at the end of that is terrific, and we're seeing the growth, with POEM procedures, and we're going to see it with ESD. Training is a big one as well, and we mentioned, in a handful of presentations, why we feel the technology is easier to train on, and we've seen that with some clinical studies and some of the experts in Asia. And safety is a big issue. So there are value analysis committees that want to see data as it relates to safety, and getting help from our clinicians in terms of the clinical validation to be able to show that is really important. So these are steps that we had to go through, but I think the wind is at our back as it relates to those. So it's the only way to bring innovation to healthcare, but the paradigm is changing because people want to be home after their procedures, and the hospitals want to actually deliver it in a cost-effective way. So we had to do that first.
I'll also add that the new products that we're developing for the general GI endoscopists are easy to use. They've been designed with the design intent that means that they don't need additional training compared to what they're using at the moment, the monopolar energy. They can pick it up, use it, get all the benefit of bipolar RF without the complexity of a steep learning curve or a long learning curve.
Carlos, so you've been involved with us now for 5+ years, and you used the first speedboat and you watched that evolve, so it's compatible with everything. You were the first person to use the microwave ablation for the pancreas, and now you see the product roadmap for the rest of the bipolar suite. Any concerns about us having the platform not only for the interventional gastroenterologist and endoscopic surgeon, but the general GI? So all of the procedure rooms doing simple colonoscopies, simple lumps and bumps, EGDs, etc. Any thoughts?
Yes, that is a good question, and I believe for you as investors, it's very important to understand a little bit that. When we met 6 years ago, we were talking a little bit about the technology and how would be the path. It's not easier the path of the physicians, to be honest. We are super nice here, right? But in terms of data, in terms of security, in terms of all the things, fields in the FDA or CA market, and all the things is really complicated. It's not so easy. And I saw it, when we were discussing about that. One of the big things that we were discussing was this need to be in the hand of the general GI, because as experts, probably we are just 10 or 5% of the physicians doing these amazing surgeries, right? Robotics for sure will help us more to have this precision. I was very impressed with the presentation of the professor from pulmonology. So this is the path, is correct, right? But to put small things like these ones, bipolar, so we reduce the complication that we can have in general GI. Let's talking about general GI. We are not talking about experts. So in general GI, we are talking about 90% from all the GI. So it's is that the potential grow now, right now? Because they have an advanced energy, but now they have an advanced energy for general GI, so for make it easier their life. So that I don't know if I answered your question, but I believe that's the grow up, the curve will be a little bit high, I believe, in the next years because of this.
I think just to say as well, this is a louder one. A few years back, when we were first looking at how you grow the revenue and you put the two a week cases in, we overestimated how quickly we would get adoption, and we overestimated the challenges that these guys would face, and how much we would face challenge through the NHS or through getting through VAC committees. And we had revenue trajectories that were more built on models than they were built on paring it back and making sure that you had a natural sort of prudency, real big prudency in the numbers. And I think what's happened as we've learned and we've gone through the process and we've taken out any potential big license deals that we could be getting in the future, we've taken the numbers back and we've been hitting all the numbers in the last sort of 6 quarters. And that's the difference in the reset in the business. Cost down, revenues at a reasonable trajectory level, giving these guys the challenge to go out and deliver aggressive revenue targets, but not as aggressive as we previously had as well. No more?
Yeah. I just wanted to add one more thing. The accessories that they had shown already, the snares and sphincterotomes, are being widely used in every hospital, every single hospital all over the world. So once that gets to the physicians, the market is just going to explode. I just wanted to add that.
I think that might be a mic drop moment.
So this year we've seen our first commercial sales of Spiderblade, the scissors. We've seen the first commercial sales of Speedboat Notch. We're now launching short variants of Speedboat Notch and Speedboat Ultra Slim for upper GI cases. And we will be deploying a new generator platform next year. So there are product launches. In the background, we're working on new software and new waveforms. Sorry if I'm stealing your thunder here. But we are developing new waveforms to get more performance out of our devices. This is in response to feedback from our doctors who, for example, when they're doing a resection with Speedboat, would like to have slightly more coag in the cut waveform to mean that they don't have to go back and do secondary coag operations with the Speedboat itself. So there are lots of things that we can do between now and in 18 months when we're deploying the full general GI kit.
So just very quickly to wrap up, I think hopefully you found today informative. Certainly I have. I've learned more from Pallav probably in the last 2 times that I've seen him, and I've seen him do a number of cases. I'd thank again the team for sitting through this long session and coming so far to help us with today. And so for me personally, I'll go back to the beginning. We went public in 2016. We didn't have a single regulatory clearance. We had a big idea. We had lots of things that we wanted to do and an aspiration to achieve some modelling numbers. I think I saw Phil Hales here, who's one of the early consultants, now retired, who helped us put the model together. So the reality is now faced us. So we understand the realities. We understand how Natalie here, who's from the US, so feel free to ask Natalie about any of the challenges that she faces in the US. I'm sure she'll give you the war stories. But what we do now see is predictable outcomes. We understand what inputs give us what outputs. And again, back to Ben's well-eloquated point, that's my mic drop moment. When I look at the bipolar products, and those are things that we've been aspirating, trying to achieve for some time, I look at our partners like Intuitive. They have been trying to use bipolar technology to cut tissue with Da Vinci, and they have failed. There's other companies that are trying to put bipolar technology into the GI market, for example, to cut tissue, and they have failed. We understand why they have failed, because we've destroyed thousands of devices in trying to make ours work. It's extremely difficult. And the absolute key is that our energy source has to be working in total harmony with the device that's delivering the tissue. Every other system in the market of note, particularly those that these guys use every day, is a generic generator using devices from any old manufacturer. And there's no integration between the instrument and the actual source of energy. And for that reason, we were talking earlier on with Richard, who's our key guy, sales manager for UK and Europe. He was at a case last week where a case with monopolar, they had to change the settings 17 times during a procedure. And that's nurses being asked to change settings. They don't know what they're changing them to. They're kind of guessing what they're doing. And that, to me, that is ridiculous, because if they get it wrong, they will cause harm, and they do cause harm. These are the complications that we get. What we have at the back of the room is an integrated plug-and-play platform. So these devices that transform the market for Ben, the user can plug it in, and the nurses, the techs that have to manage these situations, don't have to think. They self-provision the settings on the generator, so those devices work. And most importantly, they work and they cut with bipolar in a way that nobody else has been able to do. That makes the point that there's nobody in the market that could emulate what we're doing. It would be extremely difficult for them to do that. So our challenge next year is absolute laser focus with what Charlie's done. These devices are essentially at design freeze, very close to that. And what we've learned on the complex, the original products that have been the spearhead to get us noticed and positioned in the market, we are transferring into, as Rich said earlier on, with outsourcing the manufacturing and design for manufacture for those products, because they'll be immediately built at massive scales compared to where we are today. And that points to the fact that we understand what we're doing with this technology that nobody else has been able to do, and we're able to translate that into partners that we're working with in the US, other countries in Europe, as well as with Microtech in China. So the partnership with the Microtech through the joint venture that we have with Lewis and Microtech is working for us. We get the benefits of working with Lewis and his team to get access to the market. We're also working with Microtech to help us co-develop product, so they will immediately have the scale in terms of manufacturing. And we're also working with them towards putting bipolar into the Chinese market. The next stage of that, back to the question earlier on about licensing, is now that we know how, we will know how to do that with other companies where we're working with them and funding part of that work. For example, on the snare, we're about there with a piece of wire that allows a bipolar snare to be made by anybody. Now, if you look at the number of snares on the market, which Ben will be able to talk to you till the cows come home, if we can put into the market a licensable piece of wire that allows anybody who makes snares to make a bipolar advanced energy snare, that is great for us, because it will only work when it's working in combination with our energy platform. So there's the nuances of what we've been able to achieve and deliver in that plug-and-play platform cannot be understated. But again, back to Rich's point, we've delivered and executed with hard work and blocking and tackling with these guys. We've nailed our quarterly targets every quarter for the last 6 quarters. We've got no reason to expect that that's not going to continue, and these are reasonable expectations that we've set. So the licensing question about, is there anybody else beyond Intuitive where there are opportunities? We are pursuing carefully those opportunities, but we're not investing any significant resources. We don't need to. We know what we need to know, and the product is there for us to do that. So yeah, who knows whether we sign up any of those further licensing deals, but that is 100% part of our longer term strategy.